उसका पे करना है कि सारा करवाना है।
So, so today we have Miss Himani Puri with us, who is going to be a moderator of our session. Since we are doing a series of functional medicine, today we are going to uncover the complexities of metabolic syndrome or the metabolic disorders. So we have Miss Himani and Miss Ranu with us, along with our speaker, Dr. Musa. So about Himani, she is a founder and proprietor of Sattva NutriCare and a chief dietitian at Apex Hospital, Nasik. She has got lots of credibility, as you all can see her, and a well-known face of our industry. She is a program officer of IAP and Renal Nutrition Core Group. She is a chapter secretary for IAP in Nasik, secretary for Nashik District International Human Rights Organization. She is the editor of Healthcare and Medicine for online bulletin IVTR, life member of various prestigious institutes, and the list will go on if I keep talking about her. Over to you, Himani.
Thank you so much, Ankita. Thank you, and thank you for a humble introduction. Before I introduce the chairperson for today, just one line for Ankita. Ankita has been the brainchild along with Dr. Musa for this webinar series, which you have been listening to since the past 5 months. Today, the 6th month now. And we hope to continue with much more further workshops with Dr. Musa and Ankita. So credits to Ankita for organizing and helping us in planning up this webinar series here.
Thank you so much.
Yeah, thank you.
Hmm.
I would now like to introduce our chairperson for today. Ranu is a dear friend and a humble and a great leader where community nutrition is concerned. Her work in the field of community nutrition is at par. I mean, you cannot compare it with anybody, and it just keeps on increasing and increasing. From pediatrics to adults to every field and every area of community is what Ranu has been touching in. Every activity, and Ranu is always there where community nutrition is concerned. Ranu is the founder for Nutrition Punch. She is the Chief Program Officer for Community Nutrition Core Group IIP in India, an active member and the Secretary of IIP in Lucknow chapter and various other core groups of IIP in India. She's a research scholar and a certified diabetes educator and has a fellowship in clinical nutrition and certified with maternal and child nutritionist. She has sort of certified ESP and Triple L courses to her credit and has been working with a lot of females of reproductive ages in urban slums and rural areas. Her major areas of work include creating awareness about dietary requirements, healthy lifestyle, importance of healthy eating, sanitation, and hygiene to improve the knowledge, health behavior and health outcomes, and related to prevention and management of diabetes and other diseases. Ranu is a life member, and associate member to various prestigious societies internationally and nationally. I would like to hand over the screen to Ranu for the further ahead of the program. Welcome, Ranu. Thank you so much for accepting our invitation today.
Thank you, Himani, for such a wonderful introduction. And now I would like to introduce the speaker for the today's webinar, Dr. Anis Musa. And Dr. Anis is an accomplished ophthalmologist with a rich experience of 25 years. He has certification in functional medicine from the esteemed Institute of Functional Medicine. And Dr. Anis is the founder of Ultra Wellness Clinic, a pioneering institute that specializes in an array of health concerns, including metabolic syndrome, hormone health, mold toxicities, gut disorders, and autoimmune disorders. He advocates tackling roots of chronic diseases rather than merely addressing the symptom. Welcome, Dr. Anis, to this webinar. And now I'm handling this. Over to you, Dr. Anis.
Yes, thank you very much, Renu, Ankita, and Himani for arranging this webinar. And as a part of series where we talk about the different cases in functional medicine, and today we're going to focus on a very complicated case where we want to just peel the onion of each and every root cause, and then we discuss the case from the functional medicine point of view. So yes, without wasting the time, let's start today's session, and everybody is for that. And let's me start my presentation. and then we can discuss the case. Okay, so today's case is more of on a complicated case of insulin resistance. We'll be going to learn much more than insulin resistance. Today's objective, I will introduce the functional medicine. Those who are new in this webinar, I will introduce the functional medicine in little bit way, so you can understand what is functional medicine. And then we want to find out the pattern. So we see many chronic complicated cases. We just want to understand the case in detail, where we find out the pattern. What is the pattern? And I will connect the dot of dysfunction, that apart from the insulin resistance, is there any connection with the hormones, or is there any connection with the thyroid? So we're going to learn on that. I will quickly introduce the physiology of insulin resistance. So everybody know the insulin resistance is there, and that is the root cause of diabetes, prediabetes, and many conditions. But I just want to unfold what is the root behind the insulin resistance and what is the normal physiology of insulin resistance. And then I will show you what are the biomarkers or what are the lab you should look at to find the root cause of that insulin resistance, or even how you can diagnose the insulin resistance. And then we're going to learn the root cause from the functional medicine point of view. It's just not a insulin resistance. There are many things going on in patient's life and history. So we're going to unfold the root cause that will you will be familiar with the major tool of functional medicine, that is functional medicine matrix. And then we talk about the treatment part. And then finally, I will show you how we can solve the complicated case from a different point of view. So everybody is aware about we are now facing a tsunami of chronic conditions. So if you talk about the chronic condition, you look around you, and if you find out any healthy person of more than 40 years of age, you are lucky one, because as per data, 50% of patients or adult population of more than 40 years of age, they have one chronic conditions, and 25% of population, they have one more than one chronic condition. So we are surrounded by this kind of chronic condition. And after COVID, we had a sharp rise of all inflammatory conditions like diabetes, thyroid, and so many things. So I will not go in detail of the statistic, because everybody is convinced with the idea that we are having too much of chronic conditions right now there. So before we can go ahead, I want to differentiate the two category of disease, that the acute conditions. So everybody know about the acute conditions. We are dealing with any kind of trauma, infection, or any kind of emergency situation. We can say high grade fever, or this condition that is required immediate attention of a physician or surgeon or a doctor, and we need medicine for that. So here we are not talking about that acute condition. We are doing very well in conventional medicine for the acute condition. We have a very equipped, knowledgeable physician and doctor to deal with that kind of situation. But when it comes to the chronic conditions, so chronic condition means any symptom lasts for more than 3 to 6 months, and we see many patients, they are having a diabetes or a PCOD or something like that for years and years. So that condition is, we can say, a chronic condition. And chronic condition is as definition diabetes, thyroid, and you can see whatever the patients you are seeing, they have some kind of chronic conditions. So here in functional medicine, we are dealing with this kind of chronic conditions. And just for example, let's say if we are dealing with a chronic condition, then we cannot use the same maps. We cannot use the same mindset what we are treating with an acute condition. So if we are using the same tools, what we are using in acute condition, we will fail in treating the chronic condition. So I would like to teach you what are the different frameworks today from the case point of view. But just for understanding, the major difference you can see here in my slide is one condition that can have many causes. So here we are not dealing with one cause. Let's say in acute condition, we want to find out that one cause who leads to a chest pain. We want to find out the one cause for that fever. We want to find out the one infection for that infection or fever. But here, when we are dealing with a chronic condition, we are dealing in multiple causes. Let's say, for example, if you have a depression, then depression can be in a thyroid or low thyroid functions. Depression can be in a omega-3 deficiency, or maybe in a diabetes, or maybe somebody having a vitamin deficiency. So just I want to point something over here is one condition can be because of multiple causes. So we have to find out what are the causes that are active in that particular patient, and that's about finding the root cause. On the other side, if you look at the chronic inflammation, then in one patient, chronic inflammation can lead to arthritis. In one patient, chronic inflammation can lead to a cardiovascular disease, and we say rise of hsCRP or inflammation is a root cause of atherosclerosis. And if you look at the mechanism of atherosclerosis, then that's the inflammation that is happening in the arterial wall. And inflammation can lead to diabetes in some patient, or inflammation can lead to a cancer in some patient. So in one cause, so if you look at the one cause, that one cause in some patients leads to a different condition, and other patients it leads to a different things. So I just want you to convince that if we apply the same acute medicine model where we want to find out the one cause, we will fail when we look at the chronic condition, because chronic condition depend on so many conditions or so many causes. And that's what functional medicine deal, that we want to find out what are the dysfunction in that particular patient. So one patient of diabetes, you might be having a gut issues, and one patient of diabetes, you might be find out the thyroid, maybe the coexisting feature, or maybe in some patient of diabetes, you can find out the brain dysfunction. So here we need a different map. So if you want to look at the functional medicine, then we want to look at the different map or different tools we require to understand this kind of chronic condition. So let's start today's case. Today we are discussing a 33-year-old female, and she came to us with an hypothyroidism, and she is taking an 55 mcg of thyroid medicines. Apart from taking an 50 mcg of thyroid medicine, she is complained about the irregular menstrual cycle. Still, her menstrual cycle is not regular. She is complaining about the premenopause symptoms. She also complained about the body pain. She also complained about the fatigue, and sometimes she has a itching in the thighs that follow the rashes. So if you look at the hypothyroid symptom, then all the symptom right now she is complaining that belongs to a thyroid dysfunction. And when she go to a regular doctor, or she is consulting a doctor, and the doctor usually check thyroid TSH, and then when TSH came normal, this is our linear thinking in acute care model or a conventional medicine model. When we look at the symptom, all the symptoms belongs to a hypothyroidism, and when we check a thyroid, her TSH came normal every time. And then every time she is complaining about the symptoms that belongs to a hypothyroidism, and then doctor or practitioner or even some practitioner would tell the patient that you might be having a stress, and because of stress you have symptoms, and if you complain these symptoms again and again, then final diagnosis could be a depression, and she is referred to a psychiatrist, where initially psychiatrist advised, because she is very young, so doctor advised her counseling, and of course the counseling failed, and then finally she was put on SSRI. So this is our conventional linear thinking, where we look at the disease from linear point of view, that this happened, and because of this happened, because of this happened. So our thinking is linear, and that linear thinking is work based in acute disease, where we want to find out and rule out the disease one by one by one, and that way we can solve the acute condition. But when we look at the chronic condition, this linear thinking will fail. And my question to everybody, when you look at this linear thinking, my question is, when she was diagnosed with depression and when she was put on SSRI, my question and real thinking is she is deficient in SSRI? Do she has a deficiency of this medicine or this pharmaceutical? And right now the answer is no. She is not deficient in SSRI. And because of deficiencies of SSRI, she is having symptoms. No, that is not the reason. These drugs are important, but they are working very downstream for acute condition. If somebody having a severe clinical depression, then we have to use that one. I am not against that one, but that is a starting point. And we have to ask what is happening upstream, what is going on in patients' physiology, patient dysfunction or functions. That's the functional medicine meant for to diagnose the root cause. So we have to define the health, we have to rethink the disease. So let me give simple ideology of functional medicine, where we can think differently when we talk about the disease. Now just look at here. On one side, so disease and health is actually a continuum. On one side we have health, and on the other side we have a disease. So if we change our thinking and we start rethinking the disease is just an absence of health. So if we create the health by regulating the functions, if we can regulate the functions, slowly patient can get the health back. So it's just an absence of health or absence of functions in the body, and that's why slowly patients is developing the disease. And when you see any kind of diabetic patients or any kind of insulin resistance patient, the patient doesn't only have a insulin resistance, they have multiple dysfunctions over there. So in this case, we're going to unfold all the dysfunction that what she is having. So doctor is looking at just for thyroid, but we're going to unfold more than thyroid, and we want to map and complete things where we can diagnose the case and we can find out the root cause. Now, as we are talking about the functional medicine, so we want to redefine the disease. So we have to change the paradigm. So we have to change the paradigm from the disease to a health. So disease to create the health. We need a different map and different tool to diagnose the root cause. We need a tools. We need different understanding of the chronic condition, and we need a different framework. So today, in this case, side by side, I'm going to teach you the framework that will be used throughout the functional medicine model, where you can apply the same knowledge in your patient to interpret the clinical information. And as we are discussing, we are going beyond the disease, so we are focusing on functions. In conventional acute care model, we are focusing on a pathology. What the pathology is happening. Pathology is very down. So initially, patient have a dysfunction, and if you don't correct the dysfunction, they start having structural changes that we called as a pathology. So we have to change from the pathology, and we have to start thinking the functions and the dysfunction, and we have to understand the physiological system in the body. And today we're going to discuss the major physiological process that is happening in the body, and we can discuss in detail for that. And as I mentioned you earlier, that we have to think about the optimal functions of the body. So that's a continuum. So you have a one side, you have a health, and other side you have a disease. In between, you have a dysfunction, and that dysfunction we have to identify. And if you can identify the dysfunction, then we can correct the dysfunction with a different model. So functional medicine is not an alternate science. It's a basic biology-based approach where we're going to find out the dysfunction, or where we find out the root cause of that condition in that particular patient, and we correct. So if you look at the ideology of functional medicine, that's basically we want to find out the root cause of the disease, and then we want to correct the root cause. Two primary questions every chronic disease patient is asking you, and the one question that everybody is asking is how the disease develops. So practitioner or nutritionist or doctor, how I enter in your clinic, how I develop this dysfunction, how I develop the fatigue, how I develop the hypothyroidism. So what is a my history? So that's they want to know about the disease. So if you look at the right side, then you can see a tree. So we can look at the functions of the body or functional medicine model in that tree. So if you look at the root, then you can classically say that in the root we have a modifiable lifestyle factor, and that modifiable lifestyle factor you can see is a sleep, and beyond sleep that's called relaxation. And we know the exercise, but beyond exercise there is a movement that we have to understand. Nutrition and nutritional deficiency, you all are expert in nutrition, but we are going to talk nutrition in detail. And then of course we talk about the stress and relationship. So if you look at the root, then we have a modifiable lifestyle factor. And in all the patients, in all the chronic condition patients, the root is disturbed. And because the root is disturbed, either they have a nutritional deficiency, either they encounter with some kind of trigger infections, and there are some genetics for that, and they unfold that genetics with the trigger and mediator, and then they start developing a dysfunction. And because of dysfunctions in that particular area, they start having a symptoms, and what you see is just a symptom. But if you unfold the dysfunction, you find out the antecedent, trigger, and mediator, and then you find out some kind of genetic variation, and then you find out the root is the lifestyle factors that we're going to talk on today. So first and most important thing, see, if we want to unfold the chronic condition, then we require information. Now just imagine that patient is suffering with some kind of chronic condition for years and years and years, and how we can gather the information in just that and 10 to 15-minute consultation in an acute care model or in a doctor's office. That is not possible at all. We have to change the narration. We need information from the patient. So you can collect the information through forms. We are sending in some forms to the patient before we enter the clinic. They give us information. We ask them a lifestyle questionnaire, we ask them a life event and family history, and we finally ask them medical symptom questionnaire, and then we ask them many questions over there. And when they come to our clinic, we actually allot an 45 minutes to 1 hour to listen and collect the information. So that's the important part. We have to gather the information, we have to gather, and we have to put them in some format. So here, once we gather the information, we have to map and we have to find out that pattern. And that pattern I will teach you over here, and that's we call a timeline. So here in this patient, I will show you the timeline over here, and then you can just look at here. Okay, so once we gather the information and we want to plot, and we call them as a timeline. So with the timeline, we can find out how this patient had developed the disease. So in this case, you can see the patient was some kind of concern, and then we took a complete timeline from the birth. So you can see the patient have a family history of diabetes and hypertension. So what this means, it's a clinical information. See, in a chronic condition, genes are important, but at the same time, we know that genes are not our destiny. So genes are important, but they are playing in some kind of 20 to 30% role in development of the disease, but not exactly they will produce the disease. But we know that if the patient have a family history of diabetes and a hypertension, then they have a risk of developing diabetes in future. But we have to find out what are the trigger and what are the mediator that can unfold that genetics. Now you can see the complete timeline. Patient is born with a normal delivery, but in infancy, patient have a lot of cough and cold, and even that cough and cold continue in childhood. And then she was given an antibiotic frequently, and then in childhood and teens, she started developing constipation very early. Now we know that uh, gut function is very important, and if somebody having an imbalance in gut microbiome, that can leads to a constipation, or when somebody have a deficiency of these good bugs in large intestine, this patient start developing constipation. So we can see the history that cough and cold, that patient has some kind of allergy, or we can say immune system is not properly formed, or the immune system is constantly having some kind of allergy over there, and that's why there is a difficulty over there. So we can understand this kind of symptoms over there. Now she continued with the same thing, and when she entered a teenage, she started the irregular menstrual cycle, and she was investigated for that, and nothing came out, and no diagnosis was made. So she continued with an irregular menstrual cycle. Sometimes she take an OC pills that normally doctor prescribe over there, and she is managing her life in adulthood. And she went to graduation and college, where really that was a tough time for her because she doesn't like the study, and she is living in a hostel, and that was a difficult time studying a stress. She also have a broken relationship over there. So if you can see that her 18 to 25 years of age, she's struggling with an hormones and menstrual cycle, and same time she's struggling with an stress and all the lifestyle factors. Now you can see the lifestyles is in the root, and she has disturbed that root, and already she has some kind of genetics over there, and because of lifestyle changes, she is exposing that genes to a bad lifestyle choice, and because of bad lifestyle choice, she started having a menstrual irregularity or hormone dysfunction. And at the age of 26, she started the weight gain, and again the irregular menstrual cycle continued because she wanted to marry. So she was investigated, and finally they done ultrasonography, and with ultrasonography even they had not find out anything, and she has never diagnosed with the cause. But at the age of 27, she has a difficulty in pregnancy. So she was again investigated, and luckily this time, what the patient says that they had find out the thyroid dysfunction because the TSH was high, around 5 to 6, and they had started the thyroid medication, that 50 mcg of dose, and by doing some kind of hormone treatment, even with the thyroid, she had not made the menstrual cycle regular. And at the age of 28, she had done hormone treatment. And with the hormone treatment, she got pregnant. And after pregnancy, again, she had started all the symptoms that what we had discussed in current concern. And then she came to us at the age of 33, and already the diagnosis of depression was made, and she was on SSRI, and that's how she came. So here I just want you to point out over here is look at the pattern how she had diagnosed, and we can see the one major diagnosis is missed over here, and that's the insulin resistance, and that's we're going to talk about it. So if you look at in detail, then we can find out the insulin resistance, and we want to discuss that part also. So if you look at her history, then she had started some kind of immune dysfunction, some gut dysfunction, and because of immune dysfunction and the gut dysfunction, she had started the one major dysfunction that we call as a insulin resistance. So now let me discuss the insulin resistance, that we continue with the case, so you will idea about the insulin resistance. So everybody know that insulin resistance exists, but let me unfold the classical way that how you're going to understand the insulin resistance. So before we can understand the dysfunction, or before we can understand the insulin dysfunction, we need to understand the function or normal functions in the body. So that normal function is, just a minute, let me correct my video. Okay, let me continue from here. So we are discussing about the insulin dysfunction. So before we can discuss the insulin dysfunction, I would like to make you aware about, can you hear me now? It's okay?
Yes, you're
Yeah,
audible.
okay. So we are talking about the sugar function. So before we can understand, then we need to understand the normal functions of the insulin and sugar. So everybody look at my screen, and I would like to show you something over here so you can understand it very clearly. When we eat any kind of sugar or carbohydrate, even beyond the sugar, we want to understand the carbohydrate. So when we eat any kind of carbohydrate, all the carbohydrate that will convert to sugar itself in a stomach. Starting from the mouth, we have amylase. We're going to break down the starch, and we're going to convert that carbohydrate in sugar. So it's not only sugar, it's also the carbohydrate that going to convert into sugar. And we have a passive transfer of sugar from the intestine in the blood. So if you look at the blood, we only have 100 milligram per dl sugar, and that means at a given point of time in entire body, in entire blood, we just have a 5 grams of sugar, just 5 grams of sugar. So if you eat 1 cup of ice cream that contain 100 grams of sugar, or if you eat one bowl of rice that contain 100 gram of sugar, now you can see in a blood we have 5 grams, and in the intestine we have 100 gram of sugar. So body will absorb this 95 grams of sugar in the blood directly. We don't have any kind of active, very passive transfer. So all the sugar will transfer in the blood. So when the sugar transfer in the blood, we have a highest priority, because our body considers sugar is a poison. We have to anyway we have to cut down the sugar, and we have to distribute the sugar. Now the problem in the cell is we cannot store sugar. In our entire body, we don't have any storage of sugar. The only option for our body is to convert the sugar molecule into energy. That's the only way we can do it. We cannot store sugar. So if you look at the body, we only have a small quantity of glycogen. That's it. The entire body is having fat and protein and all the minerals and water. So now we have to deal with this 95 grams of sugar in the blood. So everybody, when we eat a carbohydrate ice cream, we rise the blood sugar. When we increase the blood sugar, the brain stimulates the pancreas, and we release the insulin, because our cell are designed not for sugar metabolism. If you look at the animal history and animal cell, then our cells are not designed for the sugar metabolism. And that's why sugar cannot enter in the cell directly. The gate is always closed for sugar. Now we have a mechanism to overcome this mechanism. So when we have a rise of blood sugar, this gate is always closed. Now the insulin come in a picture. Insulin open the gate. That's the key. So the insulin is actually a key of this gate. So we open the gate and then sugar go inside, and then it goes to the mitochondria, and then we convert the sugar into the energy. So this is the sugar and insulin. So sugar go in a receptor. We have a mechanism for the insulin, and then we take the sugar inside and we burn the sugar. Now, just imagine in this patient that this patient has some kind of genetics for diabetes, and simple meaning of diabetes is their genes doesn't like sugar. Understand very clearly. If you look at any patient who have a family history of diabetes, that simple meaning of that, their genes are not made for sugar, and even more than that, their genes hate sugar. They don't like sugar. So whenever she eats sugar, the genes start expressing. Whenever she has some kind of other age of 13, she has a full-blown expression of that genes of insulin resistance. Simple meaning of that thing is that genes doesn't like sugar. So whenever sugar try to enter with the help of insulin, the genes resist insulin. Genes say insulin don't act. So they do some receptor changes, they do a transcription, every mechanism is there, but in simple terms, the genes resist the insulin. So they resist the insulin, so insulin cannot work over here. And if insulin cannot work over here, you will have a rise of blood sugar. When you are rise of blood sugar, your brain will tell the pancreas, release the insulin, release the insulin. So now you can see the classical way, the genes are resisting the insulin. At the same time, the job is to reduce the blood sugar. So the second mechanism, that pancreas will come and save you by increasing more insulin. The simple ideology is there. When one insulin cannot open the gate, your body will create more insulin, 2 insulin, 3 insulin, 4 insulin. So directly, if you can see this one, degree of insulin resistance is equal to number of insulins or level of insulin. So if you have high insulin, that means you have a high insulin resistance. So that's how the insulin is creating. Now insulin has a second job. So when insulin cannot send sugar inside for energy, what the insulin will do? Insulin will convert this sugar into triglyceride, this sugar into fat. And that's why you see pre-diabetic or insulin resistance case, they have fatty liver. What is a fatty liver? It's just the deposition of fat in the liver cell. And that's because of insulin. So once you have high insulin, you see this kind of effect over there. And once you have high insulin, you will see your triglyceride level goes up. So when you do a blood report, you will see the triglyceride level goes up, and at the same time you have a low STL level. So you can see the ratio is altered. And the same insulin is when creating a fat in the liver, when liver is full, that means they will sending a fat to in abdomen. So you can see a sub-Q fat over there or metabolic fat over there. And that metabolic fat is because of insulin resistance and because of high insulin. So you can see this way. So if you want to just define in simple terms, then it means your cells doesn't like sugar. To like the sugar or if to burn the sugar, your body is creating more insulin. And that way you can diagnose the insulin resistance by looking at the biomarkers over there. But in this case, that mechanism was completely missed at the age of 13, and she has never diagnosed with the insulin resistance. And now you can look at the theory over there. There's adipose tissue responding to insulin, so whole theory. But what did I said you? The same theory is over here, and that's the insulin resistance you can see over here. And then we have a receptor what we had worked. If you have a normal insulin receptor or normal function of insulin, a small quantity of insulin that bind to the receptor, and you will take all the sugar, and your blood sugar will goes down within half an hour to 1 hour, and then blood sugar remain to a normal, and that way the insulin works. But in this case, we are seeing that finding is completely missed. So, and the another things you can observe is here, right? When the insulin is converting sugar into the fat, cell is not getting the energy. So you see many patients of insulin resistance, they do frequent eating. So they take a meal, a high carbohydrate meal, and within 2-3 hours they're hungry because the cell is not getting the energy. And this is happening, and there's a vicious cycle. Because of insulin resistance, you have high insulin, and because of high insulin, you start converting your sugar into fat, and the cell are hungry, and again you eat a carbohydrate, and this vicious cycle is goes on and on and on for years and years and years, and then you develop pre-diabetes and diabetes. So now if you again look at the continuum, same thing when we talk about the chronic disease, we always talk about the continuum. All the disease will not develop overnight. Sunday, you don't have anything, and Monday morning you wake up and you develop diabetes. That is happening in acute condition. And here we not talk about the acute condition. We are talking about the chronic condition, and that condition will take 10 to 15 years to develop. So if you look at the diabetes, diabetes is the very end stage of insulin resistance. You start with a normal genes or normal, then you have expression of that genetics that leads to insulin resistance, and many people remain for 5 years, 6 years, or 10 years in this period, and then eventually they start having a low insulin functions because pancreas cannot secrete this insulin for longer. It will tired by creating more and more insulin. So one day the pancreas will tired and it will start decreasing insulin level. And when you start decreasing insulin level, you start having a pre-diabetes and diabetes and then end stage of diabetes. But you can see the in between this 10 to 15 years, patient having some imbalance in their lifestyle, some imbalance in their mitochondrial function, imbalance in your gut microbiome functions, or imbalance in their body composition. And so many things are going on that we want to plot, and we want to find out the root cause for that insulin resistance in that particular patients. And that's the continuum you need to understand. It is not an overnight disease that develop in this patient. And this is what I said you, the insulin goes down and you will develop the diabetes. But the most important thing is that 10 years you can diagnose the high insulin level. So one important test that you can do in all the metabolic condition is to check their insulin level, and then you can find out this dysregulation. So insulin resistance you can see in type 2 diabetes and pre-diabetes, all you know. But here one important thing I would like to discuss is PCOS, and in this patient PCOS is completely missed. This patient is actually having an PCOS, but because that ultrasound came negative, doctor had not diagnosed the PCOS. But if you look at the PCOS classical case, then 50% of PCOS case, their ovary is completely normal. They don't have a polycystic ovary in that. There are different mechanisms for that one. But if you look one step ahead, then even in PCOS, you will find out the insulin resistance. And insulin resistance is a root cause for PCOS, because that insulin, when it is high, it is disturbing that ovary, and it will hold the progression of ovum at the level of corpus luteum. So you don't have a rupture of that ovum, and if you don't have a rupture, you will not develop corpus luteum, and if you don't develop a corpus luteum, you don't have a progesterone. So in cases of obesity, in case of PCOS, you will find out high estrogen and low progesterone with an high testosterone level. So PCOS, you see the insulin resistance over there. Hypertension, high blood pressure, you will find out the insulin resistance, because one of the reason for hypertension is insulin level. So when you have high insulin level, it will instruct the kidney to spare the sodium. So you have high sodium in a high insulin level. So insulin are other functions. So insulin is also the one of the root cause for hypertension in cases. Insulin resistance is also coexisting with an hypothyroidism. In this case, we have seen that hypothyroidism is there. I would like to connect the dot over here that insulin resistance also can aggravate the hypothyroid or thyroid dysfunction, and even thyroid dysfunction is also connected with an insulin resistance. And we can see all cardiac disease or atherosclerosis is based on sugar dysfunction, and that's the insulin resistance over there. So in this case, this patient had done the done the testing to diagnose the gestational diabetes when she was pregnant, but even that test failed to diagnose the pre-diabetes or the diabetes during the pregnancy. Now I would like to teach you what are the biomarkers that can help to understand the insulin resistance. So as many of you know that insulin level affect and fasting insulin level, if it is raised, then we can diagnose the insulin resistance. But the problem here is when you look at the conventional medicine or conventional lab range, then the lab range of insulin starting from 2 or 3 to 24. It's a very wide range. And let me first explain you why the wide range is there and what is the difficulty with that. So if with this wide range of 3 to 24, we are missing many patients of insulin resistance. It's very urgent emergency to shorten the range so we can diagnose the insulin resistance over there. But luckily in this patient, the fasting insulin level was 29, so we had diagnosed the insulin resistance. But I would like to make you learn that even your level is low than 24, don't miss the diagnosis of insulin resistance, because many patients are having an insulin level of 14 or 13 or 17. Don't miss the diagnosis over there. They having an insulin resistance and we can diagnose. So if you look at the functions of the pancreas, function of the insulin, then we have a difficulty in diagnose the insulin resistance. And the problem is we have a lot of fluctuation in the insulin level. And again, that insulin level depend on the insulin resistance. So let's say if one patient have a normal insulin function, then they secrete small amount of insulin. Compared to somebody having an insulin resistance, they secrete the more insulin level after they're exposed to a meal or after they're exposed to a of the food. So in that way, it's a too wide range. So in conventional medicine, it's very difficult to diagnose type 1 and type 2 or type 2, and that's why the range is very wide. But we cannot work with that acute care model while we are looking at the insulin resistance or metabolic dysfunction. So it's very, you need to understand that we have to shorten the range of insulin level and we have to understand that level. Even in many patients you find out that their insulin level is less than 10 or less than 5. Sugar function is completely normal, HbA1c is normal. Then even how you can diagnose, there are different marker you can look at the lab and you can diagnose the insulin resistance over there. And that's this function we want to learn over here, and that's the dysfunctions are here. So that's we call glucose tolerance insulin response. So if you see any patient and you see the classical signs of insulin resistance and you know that this patient having an insulin resistance, but when you look at the conventional lab or fasting insulin level and then fasting insulin level is normal, how you can diagnose the insulin resistance? And that test we can say glucose tolerance insulin response test, where you can diagnose the insulin resistance and where you can diagnose the high insulin level. See, I told you insulin resistance means high insulin, so we have to diagnose the high insulin level. And in many cases, we had seen the insulin level rising of more than 400, more than 300 within half an hour to 1 hour. And that's too much insulin. So if you have too much insulin, that means you are having an insulin resistance. So don't just miss the test. You do a glucose tolerance insulin response test, and then you can find out insulin resistance over there. So in this case, we are missing a insulin resistance because nobody had checked the fasting insulin level, and nobody and everybody rely on a PCOS like doing an ultrasound and they not find out this one. So we had find out the insulin resistance because she is creating more insulin. And even in many cases you can do a glucose tolerance insulin response test and you can diagnose insulin resistance. Now if you look at this case, then from the lab, from the information we had collected from the history, not only we had diagnosed the metabolic dysfunction, we had diagnosed the immune dysfunction, because as thyroid, we had checked the antibody and we had find out she is having an autoimmune conditions. So she has a major immune dysfunction over there. And if you can look at the timeline, then we had find out she is allergic to something, and that allergy is since many years, and since childhood she is having an allergy. Another things we had find out in the lab is methylation defect. She is having some kind of genetics, and that's why her homocysteine level is high, where we can say it's a methylation defect. And methylation defect is one of the cause for even immune system, and methylation defect is one of the cause for insulin resistance. And then we had find out the insulin resistance, what we had discussed here. And then apart from that thing, we had find out multiple nutritional deficiency that we're going to talk today. Now, primary important thing in functional medicine is not just looking at the one cause. We have to understand and we have to organize the patient information in such a way that we can tell the story that patient, because of this, you had developed the disease or dysfunction like this way, and because of modifiable lifestyle factor that is not in a correct, that's why you develop a dysfunction. That dysfunction you can see in a center, and that dysfunction we going to discuss is these are the major dysfunction that in our body. So if you look at the conventional medicine, the acute care model, we have very narrow focus. Like ophthalmologist, I'm ophthalmologist, so I look only at the eye. I will not look at the heart. If you go to the cardiologist, they only look at the heart. If you go to the endocrinologist, they only look at the diabetes or thyroid, and they're ignoring the gastro. But when we look at the chronic condition and we are seeing the patient is suffering with a multiple dysfunction, then we have to broad our thinking. We have to broad our vision, and then we want to look from the functions of the body. And this entirely the functional medicine is for functional medicine point of view. Now I just want to brief you about what are the different functions and the major function in the body. That we can see the major function in the body is our gastric system, where we eat the food, we digest the food, gut bacteria over there, prebiotic, probiotic, infection is there. So we have a gut function is there. Then the major function in our body is defense and repair. So everybody know that immune system is doing defense. But I will tell you, the defense is a very minor function of the immune system. The major function of the immune system is a repair. Each and every second your body is repairing. You only require defense when you have some kind of infection. Otherwise, you don't require any kind of defense. And when you defend, immediately you shut down the immune system. What is the autoimmune condition? Where immune system, after attacking something, it is not going to shut down. When immune system will not shut down, it will run in autopilot mode. And that autopilot is we called as a autoimmune condition. That your immune system is running in autopilot mode. That's the autoimmune condition. So immune system having a lot of functions over there. And the major function we can see in a body is our energy, mitochondria. So each and every time we are producing energy. And for your knowledge, we have a 800 to 900 mitochondria in regular cell. And if you look at the cardiac cell, then we have a more than 5,000 mitochondria in our cardiac cell. And your brain is using 25% of energy, 25% of ATP are used by your mitochondria, your brain every single second. That's the function and real power of mitochondria. And you can see many chronic conditions where you see the patient having diabetes or thyroid. Many patients that do complain that I don't have energy or low energy, I feel fatigue, and that fatigue is because of mitochondria. And if you see any patient with the chronic pain, that's mitochondria are not producing enough energy so they can sustain the muscle, and they are over there. Then we have another function is detox. Everybody know, but I would like to change the definition of detox. It's not just a detox; it's actually a biotransformation. So we are transforming chemical compound to a water soluble compound. That's a biotransformation. And second part of detox is elimination. So it's not just detox, it's a biotransformation and detoxification. That's our elimination, we can say. That's a proper word for detoxification. And then we have a transport mechanism in the body where we transport one molecule. Let's say if you want to transfer the hormones from the thyroid to the cell, we require protein for that. So we have a transport mechanism, and finally we have a communication. We can say neuroendocrine. In this case, we can see her thyroid function is not there. Her insulin level is very high. She is diagnosed with an high estrogen. So all these things you can see in a dysfunction, and we can see. So on left side, you can see the patient having some story to tell. So that is the story. that patient is entering our clinic, and you can see in the bottom we have a modifiable lifestyle factor. That's the root of the disease. And you can see sleep is disturbed. She is almost all the time sedentary. She don't play, and she has a multiple deficiency in nutrition, and she is passing through a stress. So if you want to reverse the disease, then you have to clean this matrix. Now just think, in this patient, if we can correct her sleep, if we can correct her exercise, if I can correct the insulin resistance, if I reduce the inflammation, if I increase the energy, do she feel better? If we clean these things, then she definitely feel better. She will improve the functions of the body, and we will start the functioning from the insulin resistance, because sugar metabolism, she is affected. And I would like to start from that. You can start from anywhere. You can start from the nutritional deficiency, or you can make a mixed picture. So your treatment plan may be different from different point of view, but in this case I would like to start from the insulin resistance. So as we learn, we have changed the map. So in functional medicine, we talk functional medicine is not just an different taste or different supplements. It's a thinking process that we have to change. We have to change the tools. We have to find out the connection. We have to find out the pattern. And then finally, we have to correct that imbalance. We have to correct that lifestyle. And if we can correct that one, we can change. We can change a major things in patient's life. So that way, we're going to diagnose the root cause in that particular patient. And then we want to make a treatment. Let's say, let me briefly talk about the treatment, what the treatment we had done in this case. So if you look, then we had done a dietary changes. And let me explain something over here, because I'm hearing these things for years and years with many patients. And if you take a conventional diet, it's the simple things. If you look at patient's diet, and hope everybody has seen this kind of patient, and even many of the audience right now here, they're also following this kind of dietary changes. And you ask the patient what diet you are eating, and this, yeah, you will get something like this one. Most patients, they will tell you, in the morning I will take a poha, upma, dosa, something like 1 cup of tea with sugar. And lunch, they took a 2 or 3 chapati with vegetable, with dal and rice, and they think that this whole meal is there. And in a biscuits and dinners, they will taking some kind of things. But if you look at many patients, then you will find out that there 50% of calorie is coming from the two major ingredients, that's the dairy and wheat. 50% of their calorie. Even look at your history, what you are eating from last 10 years, 15 years, 20 years, 30 years. That way you will not get the nutrition. You have to diversify the food. But primary things, you can see the imbalance in their macros. So most patient of insulin resistance, they are eating too much carbohydrate in the name of whole grain, even name of gluten-free grains, but they have high carbohydrate. Even you can see the whole grains. If you look at the rice, it's a 70% sugar carbohydrate. You look at the millets, it's 70% or 80% carbohydrate. So all the whole grains, basically they contain a carbohydrate. So when you look at the insulin resistance, as we are discussing the physiology, all the carbohydrate, that refined carbohydrate and all the carbohydrate, they're going to convert into sugar. So if you look at the diet history, then all the patients, they are eating actually high carbohydrate. And all the patients, I'm talking all the patients, they're actually deficient in protein and omega-3, or healthy fats, we can say. They are eating too much omega-3. So all omega-3, omega-6. But if you look at typical diet history, then you can find out this one. Without these things, insulin resistance is not possible. Now just imagine that if somebody having a correct micro, they have a good protein, they have a good omega-3, they have a low carbohydrate diet throughout their life, do they develop insulin resistance? No, they will not develop, because the diet is, the macros are imbalanced, and because of macros contain more of a carbohydrate, and that's why they are developing insulin resistance. So we have to change, and we have to understand, and the first thing you have to do is you have to change the macros. Then the best macro is you can do some healthy fats and healthy protein over there, and that's the primary intervention we would like to do in many of insulin resistance case. And even this diet will work on thyroid. So once you correct the insulin resistance, there is a connection with an hypothyroidism, because high insulin interfere with T4 to T3 conversion. So if you reduce the insulin level, you will have a better conversion of T4 to T3. And as we know, T3 is active hormone. So there are many things will connected with an insulin resistance, and that's why you can also correct your hypothyroidism. So that's the nutritional biomarker you can see. We had find out the severe iron deficiency. Not every marker in center. Our ferritin level is low, and then our serum iron level is low. TIBC and everything is altered. So here you can see the patient having an iron deficiency. Now, one important thing you need to understand is iron is just not for hemoglobin. Iron is a major marker or major nutrient or major mineral for energy production. So if you want to produce the energy in the cell, if you want to produce the ATP in the cell, you require iron. So if you have iron deficiency, of course, you are going to develop the anemia over there. But the main function of this iron is to produce energy. You need iron over there. So this patient having an iron deficiency, and you can see multiple nutritional deficiency, vitamin D33. Now I would like to teach you one thing over here. Here we understood clearly in functional medicine, it's not just a disease, it's a function and dysfunction and the health. So if you look at the same things in when you interpret the biomarker, when you look at the biomarker, you don't just think like normal and abnormal. You will see the whole gray area. So here you have to understand that the biomarker have a range. So you see classically the optimal range. Let's say if we want an optimal functions, then we need optimal range. So in this case, we are seeing that patient having an immune dysfunction, 33 vitamin D, that is normal in your lab. It's not normal for this patient. We consider that below optimal. And this patient required at least 80 to 90 vitamin D level. 90 nanogram per ml vitamin D level that this patient required. And same thing we can see because our homocysteine level is high, we required more B12. So if you look at the normal range of B12, that range from 211 to 940, in this case, we at least require 600 of B12 because B12 is also important for nerve functions and for metabolic function. Same way we require folic acid. So I just want to convince that we required all the nutritional parameter in an optimal range, not below optimal range. So you have to keep that things and that depend upon patient dysfunction. And this way you can see. Another things I would like to show you over here is when you look at the conventional lab, you will not find out the ratio. Let's say in our body, we have a pair, like in calcium and magnesium. They work in synergy because calcium is an extracellular mineral, right? Magnesium is an intracellular mineral. So we work in a ratio. Now, classically, you can see the calcium level is upper normal and the magnesium level is below optimal. So the ratio is not proper. So we can say we have to correct the ratio. We have to increase the calcium level and we have to increase the magnesium level and we have to decrease the calcium level over here. So also we have to look at this kind of ratio so we can diagnose. So if you look at the conventional lab, you will see the calcium level is normal. You see the lab, you see magnesium level is normal. You cannot diagnose the calcium and magnesium deficiency over there. So you have to change your thinking. You have to change your optimal range over there. And once you see from functional medicine point of view, oh, you can see the patient's magnesium level is not optimal. And magnesium is connected to metabolic dysfunction because when the insulin has to work on this one, you require magnesium. Oh, patient have fatigue. The magnesium is playing a role in energy metabolism. Yes, now I can see the patient, that patient having an iron deficiency and patient having a magnesium deficiency. So might be these minerals are playing a role in energy metabolism. Yes, they are playing a role in energy metabolism. And then I can see her B12 level is low and her folic acid level is slightly on low. Is there B and B12 is playing a role in energy metabolism? And then you open a Krebs cycle and you can find out all the B vitamins. They are important biomarker for your energy production, for mitochondria. So you have to correct all the biomarker, that B complex and magnesium and minerals and all these things. Once you correct that one, your cells start producing energy, and that's the function we have to learn. So we have to believe that patient required nutritional support, and in this patient we want to increase the decrease the homocysteine. So we want to increase the B2, B6, B9, B12, TMG, vitamin DK, and most important thing, we want to prescribe the high dose of magnesium. So magnesium going to help in reversing the insulin resistance. And as you see, we cut down all the omega-6 from the patient diet, and we are given the high dose of omega-3. One important lesson you have to learn from this lecture is there are entirely different range for therapeutic intervention, for maintenance. It's an entirely different thing. So when you work on therapeutic intervention, your dose will be different. Same, you cannot prescribe just 100 milligram of magnesium. You're thinking that your function will be reversed. You require 800, 900, sometimes 1000 milligram of magnesium in some cases if you want to reverse the atherosclerosis. So the entire range is different. So here one important thing is look at your supplement fact and you can find out the doses. So that dosage will work in patients. So many practitioner doctors come to me and they say that I'm prescribing vitamin D or I'm giving them omega-3, and they're giving just 300 milligram omega-3, the one capsule that you find out in the market, and you prescribe that one that contains 300 milligram of omega-3. How this 300 milligram omega-3 work? Same time you have to stop all the omega-6 and you have to increase all the omega-3 to 3 grams. If you do that therapeutic intervention, then you can see results in 2 or 3 months. If you don't this one, you will not get the results. So many practitioners or many doctors, they actually fail of doing this one because they don't understand the therapeutic intervention. So in supplements, you have to do a therapeutic intervention where you see the nutrition will work like a medicine. That's the important lesson you will learn from here. And then lifestyle, everybody know that we have to work on lifestyle in diabetic patients. The important thing is we have to do the anti-gravity exercise because muscle can pull the sugar and they will reduce the blood sugar within 2 hours. And there are many techniques you will learn that will help you in controlling the insulin resistance. And that's the lifestyle intervention. Now tell me, if you do and improve and this kind of intervention, if you decrease the macro, if you change the macro, if you increase the protein, if you increase the good fat, if you increase the omega-3, if you cut down the omega-6, patients start doing exercise, patients start sleeping, feeling better, patient improve the energy, do you change the patient's outcome? Of course, yes, right? So you will change the insulin resistance, you cut down the insulin level. When you cut down the insulin level, first thing patients start having a normal menstrual cycle, patients start improving their hormone functions, and even some patients decrease the thyroid dosage. And then patients say the same thing, they reduce the weight, they're improving their mood functions, and they're improving their fatigue. So that's the progress in this patient. So that is how we're going to understand the case in detail. And then we're going to work on specific function. Like in this case, we are started from the insulin resistance. We are started from correcting the basic nutrition. Once we correct that one, we're going to focus on the different function. Like in second phase, I would like to work on immune system. I would like to correct it thyroid in more detail. And if you work on thyroid, we can find out some imbalance in the gut microbiome, or we can find out some dysfunction in the immune system. But when you work on this way, sometime when you fix the one problem, you can have an effect on other systems. So try from basic one. You can correct the basic nutritional deficiency and you can correct the basic dysfunction. And then in any case, if you find out the insulin resistance, start working from that because that is a major function. And if you look at all the hormones in our body, then we have insulin as elephant because it's secreted in high number. So if you can control that elephant, thyroid is a minor function. So if you look at the thyroid hormones, they secrete very small quantity. So you have to work first, you have to chase the elephant and you have to control the elephant. And if you control the elephant, many of your function will be controlled. Many of your functions, you will improve the energy, you will improve the mitochondrial functions, and you improve so many things over there. So I just want you, don't miss the elephant in the room. And that elephant is your high insulin level. And then I would like to announce that you can learn more thing in a functional medicine. What I showed you is just an iceberg, that the insulin resistance case, how you can discuss and how you can find out the root cause of insulin resistance. But there is something more in a functional medicine that you can learn. And this is, I just want to show you over here that what you can learn in functional medicine. Functional medicine, as I told you, that it is not an alternate science. It's a basic foundational science where you can learn. So one major dysfunction that the iceberg we have discussed, that is blood sugar regulation, and only we have discussed the insulin resistance, but you can see how you can diagnose the insulin resistance with glucose tolerance test, and how the insulin resistance is connected to the inflammation, and then what is the fasting level, what are the supplements you're going to prescribe in the insulin resistance, what are the index you will look to find out the insulin resistance, and what is the different biomarker that you will learn in diabetes and pre-diabetes and how you can reverse the insulin resistance. Then also there is a connection within blood sugar regulation to your cardiovascular system. and you're going to learn more in cardiovascular disease like high cholesterol, how to interpret the cholesterol, how you can confidently say to the patient that stop anti-cholesterol medicine. There are whole science behind it, and then we're going to provide you the tools that you can understand the cholesterol in better way. I guarantee you, many doctors don't know beyond total cholesterol. So usually conventional medicine, they look at the total cholesterol. If it is more than 200 and the patient have family history of heart disease, they will prescribe you statin medicine over there. But that is not the story. You will learn that what patient will require the statin medicines and what patient will not require the statin medicines or anti-cholesterol medicine, and how we're going to interpret the cholesterol. What are the root cause behind the cholesterol? And there is a direct connection with the insulin resistance with a metabolic condition. So whole metabolic cardiometabolic diet plan, you will learn the carbohydrate, you can learn the macros, micros, and the one most important thing is calories important. You cannot put the patient on a long-standing fasting when you took at the metabolic syndrome. And then you're going to learn the gut dysfunction. There are many gut dysfunction you can learn. What is the prebiotic and probiotic, and what are the functions of the digestive functions of the gut? What are the imbalance you can see? What are the SIBO and SIFO, and what are the infections you will develop in a gut, and then you will learn. The simple thing is, let me ask a simple question. When you see the patient having a lot of bloating or gas, do they are eating a gas? Why they are having a bloating? Is there anything in the body who is producing the gas? Which kind of gas they are producing? Why they are having a bad breath? Why always patient says that after eating something I will have a headache? So you can see a lot of dysfunction in the body, and that's some kind of infection that is going on in patient's gut, and that leads to the gut dysfunction. And then you will learn whole sort of thyroid dysfunction. So I mentioned you one point and one connection by the insulin level. There are many other connections with the thyroid functions like an high cortisol, inflammation, what is the T3 and T4. Not always increasing the dose of thyroid medicine is going to help the patients. Many patients I see, like in this case, you are seeing the patient is already taking 50 mcg of medicine. Even with that medicine, she is having symptoms. So what I want to convince you is that all the time, it is not important to increase the dosage. And if you increase the dosage, sometime you do a mistake because you have to understand the physiology that T4 is converting T3. And in many patients, we have seen the ratio, like I show you the calcium magnesium ratio. So in all the patients, we have to look at the T3 and T4 ratio, and that determine the metabolism at the cell level. So you have to think beyond the conventional point, and that's you will learn about in a thyroid, and that's all thyroid function you can learn, and what are the nutrition is important. So you learn all the physiology of thyroid, and then we're going to discuss about your adrenal hormones, sex hormones, and then we're going to teach you the health and stress and coaching part, how you can change patients behavior. At the end of day, we know that we have to change the lifestyle, and the important thing is patient cannot change lifestyle. We have to teach them, we have to coach them, right? So do you know who is the number one inhibitor, or who is preventing the patient to change the lifestyle? Patient himself, no, nobody else. So there was some kind of mindset, there was some kind of thinking, there was some kind of subconscious mind going on, and because of that subconscious mind they cannot change their lifestyle. So you can empower the patient. So that's a coaching you can learn, and coaching is important part in functional medicine. If you learn the art of coaching, you can change patient's lifestyle, and if you can achieve the patient lifestyle change, that's what we learn in lifestyle diseases, and that's the important part. And of course the important part, you already know the nutrition, but we want to teach you beyond food. And that beyond food is what is a therapeutic intervention in nutrition, what kind of nutrition you're going to prescribe depending upon dysfunction. So how are you going to prescribe the thyroid nutrition, how are you going to prescribe your metabolic dysfunction prescription. So we're going to teach you the nutrition beyond your food, because food you know very well. And then we're going to discuss the detox. So we're going to teach you in a brief all the functions of the body, what we have discussed today in great detail. And we're going to teach you how you can correct the dysfunction. And first and most important thing, how you can diagnose with a biomarker, with an history, the dysfunction you can diagnose, and you can teach that dysfunction. So those who had attended our foundation course, many of participants right now here who already attended our foundation course, and those who are attending our foundation course, they can enroll for the full functional medicine course, functional medicine in clinical nutrition, that we are starting our next batch on a 5th August. So those who are interested, please take a screenshot and contact our team, so you will get the more information over there. And those who are registered for this event, they will get one bonus toolkit. We're going to send you how and what are the important fat, or what are the important oils, and all the oils, how you're going to prescribe, what are the importance of oils, which oil you're going to prescribe. So we'll get a toolkit, and you get the information about the oils and what kind of oils you should stop it. So you get all information in your email. So just watch the email post webinar. So we'll get some information over there. Yeah, Ankita, that's it from my side, and we can open the session for Q&A. If anybody have a question, then they can unmute your mic, or Renu or Ankita, you can just let me know the question.
Good evening, sir.
Yeah, Tani Chopra, please go ahead. But if you can turn on the camera, if you can turn on the camera, it's better. Everybody can see you. We don't like to talk to a black window.
All right, sir. So actually my question is, how do we tell how many mg of a particular supplement should we give to a patient?
Yeah, that's the therapeutic intervention I told you. Depending upon patient's factors like patient biomarker, or depending upon patient's condition, we can advise them. So there are a whole range of therapeutic nutrition and whole range of maintenance nutrition, but you can start the therapeutic nutrition over there, and that's depending upon patient to patient. So let's give you a simple example. Let's say the patient having a normal immune functions. In that patient, if that patient having a 30 or 40 nanogram per ml vitamin D, that's perfectly fine for him. But if you are dealing with an immune system dysfunction, like the same patient who are having an autoimmune conditions, his HSCRP inflammation is high, then that 30 dose will not enough for that particular patient, because we have to shut down the immune system, right? And if you want to shut down the immune system, we require high dose of vitamin D. Like in that case, I would like to prescribe the high dose of vitamin D. Like I want to keep the vitamin D more than 90, above optimal level, or above standard level. So 90 vitamin D will help that patient to calm the immune system. So the range is different with different conditions. So that's what the learning is. The learning is in which patient you're going to prescribe what doses and what you're going to monitor over there, right? Because we have to balance both the things. Important thing over here is, had you seen any patient with an vitamin D or vitamin D toxicity? Ask a simple question to your doctor. Not even single case in my career.
Not even.
Right? So it's a whole fear, and the whole fear is produced by the pharmaceutical industry, that vitamin D has to be this one. This will going to create a problem over there. Last time from the food inspector, he had said, I had heard one case died with a high vitamin D.
Yes.
And then I tell him that, do you know that the third most common cause of death in entire world, it's pharmaceuticals.
Yes.
Right? Can you compare this one? No.
Yeah.
Don't fear with a high dose of vitamin D, but you should know this one. When, what, and how we're going to prescribe the vitamin D or any nutrition in high doses. Yes, we can prescribe. Right? So that's the art of that's the learning. So learning here is, see, in conventional medicine, what we are taught about the scientific stories. We are talking evidence-based medicines. We want to look at the evidence. But if you look at the research, then evidence is only exist in randomized control trial, just 13%. And even in that evidence, in research, in that evidence, physician opinion is considered to be evident. Can you believe it?
Yeah.
So if you're a practitioner, then your opinion is a evidence.
Right.
And what is that? That is art. So functional medicine is not just in science, it's a combination of art and science. You learn the art, right? Apart from your science. So science is important, science is there, but you have to learn beyond science. And that is, I can say, you change your narrations from the practitioner to a healer. There's a bigger philosophy over there. but you should learn the art of healing the patient.
All right, sir. I had another question linked to it, sir, if you don't mind answering that as well. As you said, our body doesn't really like sugar in a sense. It's bad for our functioning. And also, does that also include the sugar we get from fruits, or is it only restricted to the refined sugar?
So you can divide in a two part, like an artificial sugar and a natural sugar. So natural
Mhm.
sugar you can find out in a fruits, fructose.
Mhm. Yes, sir.
So yes, and that's why fructose is also considered to be antioxidant. But yes, small quantity of sugar or fructose you can take it. But I really hate the
Mhm.
artificial sugar or white sugar.
Yes,
Even
sir.
in some patients, even in diabetic patient, let's say it's not all and none. Like
Mhm.
so we cannot say like fruits are always bad. Or we cannot
Mhm.
say always fruit is always right.
Mhm.
Let's say if you're a patient of 300 sugar, what you will do? Would you like to prescribe the fruits?
No,
No, because they are going to
definitely.
convert. Definitely, they're going to convert into sugar. So fructose
Yes,
is
sir.
equal to sugar. So
Mhm.
if you give fructose, what will body will do? So you want to
The
give a
body's ultimately.
small quantity of antioxidant, and you want to give a large
Mhm.
dose of fructose. The body will create the insulin, and insulin will convert the same dose.
Absolutely.
Yeah, same dose. So in that case, all not required. But you are some
Mhm.
patient who require the antioxidant who only oxidative stress. You're going to prescribe the fruits.
Yeah,
So
that's
that's
okay.
art. That's art. That's okay for him. So we cannot say all or none for anything. Even insulin is important. So we cannot say that everybody should shut down the insulin level because insulin also required for the
Mhm.
protein synthesis. So it's not just an one way we can say
Absolutely.
like insulin is always a bad. We cannot say it's a context of the patient that we want to interpret the information
Mhm.
that is coming, and then we apply our functional medicine background knowledge, and then we interpret in that way, right?
All right, sir. Yes, sir. That'll be it, sir. Thank you, sir.
Yeah. Anybody have a question?
Thank you, Dr. Anis. Yeah, hello.
Yeah.
Thank you, Dr. Anis, for such a wonderful and informative session. Uh, Doctor, there are some more questions which we are going to take. One question is from Shilpa. Can we change the ratio of the carb and protein to 50% by giving meals in each serving?
See, if you look at the macros, then if you look at the diabetes and macros, then I would like to first correct the protein. First, you have to understand these things. That if let's say in the insulin resistance, we understood that patients' genes don't like sugar. So in fact, patient's cell doesn't like sugar to burn. Then if we ask the cell what you like to burn, and then cell will tell that I would like to burn a fatty acid because fatty acid don't require any kind of insulin. They can enter in the cell, and if you can prefer a short chain fatty acid or medium chain triglyceride, that's the best to convert into energy, right? So if you look at this one, the first thing is you have to correct the protein, and everybody know the protein requirement is 1 gram per kg, but you can increase to 1.2 depending upon your patient to patient. But I would like to first correct. Once you correct this one, so many problems will be solved, and then you're going to correct your fat. And as you know, you require at least 30. Everybody requires 30% of fat in their diet because our whole body is fat. Our brain is fat. Our liver is fat. All the internal organ is fat. So we require good fat. So 30% fat everybody required. I would like to increase to 50%. Now just imagine we had increased the 20% of protein, 45 to 50% your fat, good fat, and then the remaining part is vegetables, and the carbohydrate is 20%. So if you want to work on diabetic patient, this is the ratio you're going to work in patient, and that ratio will work best in many patients.
And one more question from Tani Chopra. How can we tell how many mg of a supplement we should give?
Yeah, already I answered with the Tanu,
हो सर.
so we can skip this
सरचा
question.
फोन होता ते जे आपले रेग्युलर पाउचेस आहेत ना अल्युमिनियम पाउचेस ते म्हणाले संपत आलेत तर त्याच्यामध्ये काही चेंजेस वगैरे नाही करायचे तर आपल्याला
Please, anybody can understand this language, then please translate this language for me,
लोगोच्या वरती का ओके
or we can go to the next
No,
question,
there
please.
is somebody else who is by
सगळ्या ह्याच्यावरती जे
unmuted.
डोस दिले तर जसं आपले
Can I
बाकी
request
लिहिलेले
others
असणार
to mute
फॉर एक्झाम्पल
themselves,
एनसी
please?
टीएनसी
Soham, can you mute
मग ते
yourself?
वरती फक्त तेवढं डोस फ्री टाकून घेऊ का
She's
ठीक
talking
आहे
on the phone actually.
Pradipta, can you look into it once?
ठीक आहे त्यामध्ये आर्यन वाल्यांची बोलून बघते ते बोलले करू शकतो तर मग ओके ना मग तसंच
Yes,
ठेवू.
ma'am. Continue.
हो
Yeah, sure.
चालेल.
Ranu, Dr. Musa, you can go ahead.
Okay, we can take a new few more questions.
Yes.
Dr. Musa, I have one question for you. So you
Yeah,
spoke
please.
about the macronutrients. How about the micronutrients where insulin resistance is concerned and where the diabetes is concerned, especially zinc?
Okay, so before the zinc, I would like to correct the first major mineral. That is, I already talked about the magnesium. I would like to correct the magnesium first, because magnesium is important for insulin sensitivity. And if you look at the cholesterol, then magnesium is important. It's considered to be a calcium channel blocker. So if you look at the whole metabolic syndrome, then you can find out the magnesium has an important role in all the functions. Like if you look at the hypertension, then in a medicine we use a calcium channel blocker. So what is a natural calcium channel blocker? It's a magnesium. What is a natural statin? It's a magnesium. And do you know that we produce the ATP? How we store the ATP in a cell is with the magnesium complex. It's the magnesium ATP. So we require magnesium in each and every step of energy production. We require magnesium for each and every function of the insulin. Now coming first, you have to fix. So you cannot fix zinc before you can fix the magnesium. You cannot do that. So first you have to fix the magnesium. Second mineral I would like to fix is iron, because iron, if you look at the energy production in a mitochondria, from complex 1 to complex 2 to complex 3 to complex 4 and 5 finally, we require iron. So iron is that part. And then third thing I would like to fix is B complex, because B complex is playing a major role in energy production. And then I will think about the zinc. Zinc is very important, but I will consider zinc very important for immune point of view, because zinc is very much important in immune. So if I see a patient where the immune system is disturbed and the same time they have inflammation and same time they have metabolic dysfunction, I would like to prescribe zinc with a magnesium, because in
Okay.
that way zinc will help in controlling their immune function. And even zinc is considered to be very effective in anti bacterial. So when you prescribe any kind of any system, when you prescribe the antimicrobial, you should create a zinc. So that way you can correct the zinc, and zinc has to be corrected. Yeah, zinc is very important, but I would like to consider zinc primary for immune system and secondary for metabolic function.
There have been a couple of cases which I have come through where the patient develops insulin resistance, and we sometimes go as high as 100 IUs in a day, and still the patient persists hyperglycemia, especially in the ICU.
Yes, that's important. So now you can see, classically you say that patient having a severe insulin resistance, even that 100 IU of insulin level is not working in that particular patient. So just imagine the mechanism what we are talking about. The cell doesn't want to listen to the insulin.
Correct.
They have a very high amount of these things. Then why you want to feed sugar as a fuel? When child don't want to learn something, why are you teaching the maths? Just show him art, show him other subjects, and he will definitely love that subject to learn, because cell ultimately want to survive. We have a genes coded that for survival. Only we have to provide the right fuel. So my question to, even in that case, why you want to prescribe the sugar and insulin? Instead of prescribe a small medium chain triglyceride, just look at the patient how they're responding and how the cell is responding with the medium chain triglyceride. You don't require the insulin at all.
Correct.
Right? Correct. So in your case, even let's say that patient having 100 IU of insulin you prescribe, and even the cell is not responding to that one, then you have to correct the rest of dysfunction. Like they might be having magnesium deficiency, and you can correct the insulin sensitivity. That's what you want to learn, right? So that way you can increase the micro minerals like an chromium, like an magnesium, like an zinc. You can prescribe, and the patient having this kind of minerals in their cell, then of course cell will listen to the insulin. It will not going to just ignore that 100 IU of insulin level. But you see this kind of patients in ICUs.
Right. Yeah. Also, like, do you have any suggestions on the on the formulation of the protein supplements which are available? I mean, do you prefer
Yes,
type formula or something?
first thing you need to understand is protein. Our body has our own mechanism to develop or manufacture the protein. We don't require protein. First thing, we require amino acids. Protein cannot be absorbed, and if we absorb the protein, that's a disaster for the immune system. Because immune system will react to the protein. So first thing is we require amino acid. And why we require that amino acid? Because we have our own manufacturing system where we're going to create the protein in our own cell. So first thing is we require amino acid. And that's why we have a digestive enzyme. So if you look at the entire stomach, we have a stomach acid. So what the stomach acid will do? Stomach acid will break down the long chain of protein, whatever the protein you are eating. It will break down all the protein in small chain, small chain. And now just look at your patient. If your patient is on any kind of antacid, they cannot break down the protein. So you have to find out the formula that have some kind of protease that can break down the protein, right? So first thing is you have to find out any kind of clean protein. We have seen many proteins, they are not clean. And even if you look at the whey protein, and don't go for isolation and very high 95% of protein because they are very processed. You can find out any formula, they contain 80% of protein, they've done by hydrolysis, that you can have an intact protein. And if you're damaged protein, because protein is a long chain of amino acids, so if you break down any chain, that will disturb your metabolism, that will change your protein structures. So you should having an not denatured protein, you should not have. You should having a natural protein. So don't go for any kind of 95% of protein over there. They will not going to work. They are more inflammatory proteins. You can find out any kind of whey or plant protein, but that has to be converted to amino acid. So they should be having a digestive enzyme over there, and they can break down. And of course, we have seen many formulas, they have a high amount of alternate sugar. So they will write down in the formula, 0 sugar, or they don't have sugar. But if you look at the carbohydrate, they have a high number of carbohydrates. So don't just look at the sugar only. You should look at the carbohydrate. And as we learn, the net carbohydrate or starch is equal to sugar. So it's going to convert into sugar. And many artificial sugar, they disturb your insulin and gut microbiome. And we had seen some news that some stevia is creating a problem, but that is not exactly what is. So if you are going for any protein supplement that contain a stevia extract, specific stevia extract, right? That contain a 95% of stevia extract in very small quantity. That is not going to create the insulin resistance or increase the sugar level. So you can go with that kind of sugar over there, but be aware of other artificial sugar over there.
Correct, right. Thank you so much. Great insight
And
from
another thing is, as we are discussing, we don't require just a protein. Make you understand this one. Our cell is not just a protein. We require phospholipids, we require good fat, right? So that makes your cell change. The fat is important, cholesterol is important. So find out the formula, they contain protein and phospholipid or some kind of good fat over there that will help you in building rebuild your cell. So when you think about nutrition, don't just think about nutritional deficiency. Your thinking should be different. Your thinking is to rebuild the cell. Let me give simple idea about it is, if you look at the cell, then everybody know that our cell regenerate. Like our skin layer regenerate every day. So if you look at your outer layer of skin, then every 24 hours you have a brand new skin. If you look at gut epithelium, every 7 days you have a new gut epithelium. Can you believe it? Every 7 days. So if you have gut dysfunction, then every 7 days you have a chance to rebuild your gut. So if you look at entire body, then I can say with the confidence that 60 to 70% of body regenerate every 6 to 9 months. So every 9 months you have a chance to rebuild a body. So just think beyond of nutritional deficiency. Just think of rebuilding a cell, rebuild that cell. And if you think that way, then you can work on a therapeutic intervention plus maintenance plus correcting your diet. That way you can achieve rebuilding a cell.
correct, right. Thank you so much. Thank you. Ranu, do you want to take any further questions? We have time, I guess, for that.
Yes, Himani.
I want to ask one question. Can I?
Yeah, please go
Yeah, sure.
ahead.
Good evening, sir.
Good evening.
Sir, so when we talk about the proteins, there are many supplements available with amino acids like EAAs or BCAAs or glutamine. So how do we decide on this, that which patient should be given what? Or is it better when there is a compromised digestion in the patient, we prefer amino acids rather than doing the whole protein supplement?
Okay. See, as I told you that we're going to decide upon depending upon the patient to patient and condition to condition how much protein they require. Now, first question is when we going to prescribe the amino acid. Amino acid is prescribed, and which amino acid we prescribe and when. So first thing is amino acid should be prescribed when we see the patient have difficulty in digestion or patient have a severe chronic condition or patient in an ICU or in a in some kind of formula that we want to feed it. That's amino acid, because we think that patient cannot convert the protein and they require the amino acids. Same time, you will consider that the patient, the protein requirement of any chronic condition is higher than a normal person. And second information is, as we age, we require more protein. So if you are working with any adult, maybe they require 0.8 gram of protein, but if you see the old age, they require more protein. Like you can consider 1 or 1.2 gram per kg. So that way. So first lesson we are learn is the more chronic the patient, we require more simple digested protein over there, because they already having a low stomach acid or they have a compromised digestive system over there. So they will require the amino acid over there. And then second thing is, you always choose the protein. They are simple to digest. Either you can choose a plant-based protein or a whey protein. There are two things, simple protein are there. Or you can also think about the collagen, because collagen is a very simple protein that can be digested, because it's a 3 amino acid and you can digest the protein over there. Now, if you look at the different amino acid, then different amino acid has a different functions over there. Now, if you look at the gut dysfunction, then you will prescribe the L-glutamine. So glutamine is a primary amino acid for gut healing. Also, glutamine is for muscle recovery. Right? So if you see any kind of patient having a low muscle mass, or if you see the diabetic patient, you will prescribe the glutamine, because glutamine is both the way. Important thing is the dosage. And therapeutic intervention, when you do in a gut things, you may require 20 grams of glutamine, even more than that in some patients. Because understand this things, every 7 days you have a chance to rebuild the gut. So every day your gut is requiring the glutamine amino acids over there. But while working in a weight loss, you require L-carnitine. So carnitine is amino acid that can bring the fat. When you work on mitochondria, so the amino acid sequence required, maybe the carnitine you required. And then if you are working on detoxification, then you require sulfur containing amino acid. Anybody know which is the sulfur containing amino acid?
Taurine, lysine,
Taurine, yes.
choline.
Choline. So N-acetylcysteine is a major detoxifying amino acid. So NAC, commonly it is called as a NAC. So that's taurine is also the sulfur containing amino acid. And why we need a sulfur? Because sulfur is a primary conjugating substance that can convert in a phase 2. So we require sulfur over there. So different amino acid, yes, different amino acid is a different function. And then you require a protein. So select the protein based on your patient's condition and patient severity of disease.
Sir, can you repeat? You said we require sulfur-containing amino acid for what condition?
For any kind of detoxification.
Detoxification.
So let's say if a patient having some kind of detox and you're working on detoxification, you have to work on sulfur-containing amino acid.
Correct. Okay. Sir, beta-1 has rebuilt protein which has MCT oil along. So what is the specific reason behind combining these two proteins together?
As I told you that in a cell, if you look at a cell, then we not only require the protein, we require the phospholipids over there. So you find out the phospholipid over there, that's the formula that we had created and clinically research over there. So you can find out different phospholipids. So if you look at the cell membrane, then our cell membrane should be having if you look at the cell membrane structure, then we have a two layer of lipid over there and bilayer phospholipid over there. And this two layer phospholipid is actually a heart of all the receptor. Now you look at the insulin resistance. The insulin bind, where did insulin bind? The insulin bind on the surface of the cell, and then surface is phospholipid, and then your receptor over there. So the backbone of your cell is actually a phospholipids. It's a lipid, right? So that's why we just want. So our thinking is, we don't want to just correct the nutritional deficiency. Our way is to rebuild the cell, and that's why we want to correct all the nutritional deficiency for a certain period of time. Just think about the duration is important. You cannot prescribe the phospholipid for 1 day, 2 days, 2 months, right? It's an ongoing process. And if you want to rebuild the cell, then you have to provide that for 6 to 9 months. Where are you going to change the physiology? Where are you going to change the cell? And that's why you will change the physiology of that particular cell.
Thank you, sir.
Yeah.
Hello.
Yeah, please go ahead. Yeah, Renuj.
Dr. Anis, one question from Sakshi. She wants you to explain what is HOMA-IR test.
Okay. So if you look at the science and HOMA index, that is a for insulin resistance. So in previously, many doctors and many research scientists had find out the way to figure out the insulin resistance, because we know the insulin resistance since many years, more than 100 years. We know that insulin resistance is playing a role in diabetes and all, but nobody yet came out with any specific test that we can diagnose the insulin resistance. So many attempt was made to diagnose the insulin resistance, and the two attempts, one is called HOMA index and other is Quickie index, but they are based on two parameter: fasting blood sugar and fasting insulin level. So they have a whole formula behind that one, and they will find out the HOMA index and Quickie index. But here difference is, if you have high HOMA index, that suggests the insulin resistance. If you have low Quickie index, that suggests your insulin resistance. But in many cases, you will find out the normal insulin and normal sugar. In that case, if you want to diagnose the insulin resistance, like in our case, we want to run a full-fledged insulin response test, and that way you can diagnose the insulin resistance. So HOMA index is basically meant for insulin resistance over there.
Thank you, doctor. And doctor, one question from Parul. I have one child patient who is just 8 years old and dealing with insulin resistance. I am giving low carb, high protein diet, but doctor put her on orlistat and metformin, 250 mg. I'm afraid of side effects. What's your take on this?
See, if you look at the data, even we don't have a data for statin of less than 40 years of age. So I will not prescribe any kind of statin drug of less than 40 years of age. I would like to stop the statin drug in this case, because this is the 8-year kid, and the real question is why he developed the insulin resistance at this early age. The primary reason is having some kind of inflammation over there, and usually I see the inflammation is coming from the gut. So that's the problem. So you can just find out the root cause of insulin resistance in that particular case. See, we require statin not for everybody. Majority of patients we don't require the statin drug, and even if you look at the research for statin drug, statin is one of the reasons for developing early diabetes. So even in that case, I would like to stop the statin medicines.
Thank you, doctor. And one more question from Surbhi Prajapati. Sir, I am pre-diabetic and hypothyroidism patient, but when I take low carb diet, I am always suffering hypoglycemia and migraine. And I have to take fast sugar finally to feel better. Can you please guide on this?
So basically now look at the information. So what the information is coming, she is having an diabetes and she is having an pre-diabetes and she is having an thyroid, two condition. Now we don't know about her insulin level, but guess she's having a pre-diabetes, so she must be having an high insulin level, and that's defined the pre-diabetes, or she might be having a low insulin level. So if she has difficulty in following the low carbohydrate diet, I don't know what kind of dietary changes she is following, but important thing is we have to maintain the macros. So low carb doesn't mean that you cut down the carbohydrate and you restrict all the calories. That means we have to maintain the macros. So we have to shift the metabolism. Important thing is, in a pre-diabetic, in a diabetic, in a pre-diabetes, we have to shift the metabolism from the sugar to a fatty acid metabolism. That's the important lesson. So if you shift the metabolism from the fatty acid to the fatty acid, you will not have hypoglycemia. The body can run on a sugar. See, body have a mechanism to convert and maintain the sugar. We don't require sugar in that way. So if you're having an hypoglycemic attack, that might be the reason that you are having a high insulin, or you having some defect in insulin resistance. So if you want a correct answer, then I think you should do a glucose tolerance insulin response test, where you can find out how your cell is responding to sugar. So one of the reason for this hypoglycemia in case of insulin resistance is, let me give a simple idea about this one. As we are discussing about the insulin sensitivity, right? We have seen many patients that up to certain point of blood sugar, they have an insulin resistance, and suddenly if they cross that level of sugar, suddenly they start having an insulin sensitivity. Let's say in different terms, let's say if you are scolding a child, it is not listening to. But if you raise your pitch at one pitch, your child will listen. Same thing is happening in the cell. Certain amount of sugar and certain amount of insulin, cell is not listening, and suddenly the cell listen to the insulin and they will take all the sugar inside. That's the cause for hypoglycemia.
Thank you, doctor, for your valuable insights. Over to you, Himani.
Yeah. Thank you so much, Ranu. Thank you, Dr. Musa. As I can
I'm
see,
sorry. I just wanted to say one thing. Please, apologies. I wanted to ask, are we going to get the recording for this, please? I was in the hospital. I mean, so off and on, I had to miss certain parts. And excellent, sir, the discussion you've given us. But I would really appreciate if we can have the recording, please.
no, if you are in the WhatsApp group that has been created, we'll try to share the link of the recording once it's uploaded
you.
on the channel.
All right.
We'll do
Thank
that.
you. Thank
Okay?
you so much.
Thank you so
Thank
much.
you.
Thanks. So Dr. Musa, as I was seeing from the chat, lot of interest from lot of, as I said earlier, for the courses in functional medicine. So everybody's looking forward to listening to more to us from you. And anybody who wants to join can join in for the online program which is available. We would be planning for a physical in-person workshop also very soon. If you stay tuned to the WhatsApp group and log into the group, we would be updating about it soon. So thank you so much. Thank you, Ranu, for the wonderful session. Thank you to True Healthy for giving a technical support. Thank you to Ankita being the main leader and the moderator and coordinator for the entire webinar series. Thank you so much. Thank you, Dr. Musa, for being present here. And thank you, Dr. Arzu, who has been silently and very nicely, patiently answering all the questions on the chat here. Thank you so much, everybody, for being present here. And thanks to my participants for being here. Thank you.
Yes, thank you very much for listening. Have a nice weekend. Bye-bye. Take care. See you next month with a new case. Bye-bye.
Thank you.
Take care. See you soon.
Bye. Thank you all.
Bye.